Okay, I'd like to welcome Scientia Professor Valsamma Eapen, who is an internationally recognized child and adolescent psychiatrist, researcher, and academic leader based in Australia. She's a Scientia Professor and Chair of Infant, Child, and Adolescent Psychiatry at the University of New South Wales in Sydney, and head of the Academic Unit of Child Psychiatry in the Southwestern Sydney Local Health District. Professor Eapen's work focuses on neurodevelopmental disorders, including Tourette syndrome, autism spectrum disorder, ADHD, and early life determinants of mental health. Her research spans genetics, clinical epidemiology, early intervention, and translational models of care that bridge research and frontline clinical services. She is the director of the NHMRC Center of Research Excellence in supporting child and family health for priority populations, and has held numerous national and international leadership roles, including president of the International Neuropsychiatric Association. Professor Eapen is widely published and recognized for her contributions to improving early identification, family-centered care, and long-term outcomes for children with neurodevelopmental and neuropsychiatric conditions. For the Ryan Lawrence Tourette Syndrome Foundation Mover and Shakers series, Professor Eapen brings a global perspective on early intervention, multidisciplinary care, and the future of research in Tourette syndrome and related conditions. I'd like to welcome Professor Eapen to our show today, and I hope she can give us some insight on her work for families and friends and newly diagnosed individuals with Tourette syndrome. I'd like to start with the first question I'd like to ask is, for families who are just receiving a diagnosis, how would you explain Tourette syndrome in a clear and reassuring way?
I'll give you the long answer, but obviously based on who is in front of me, I would make adjustments. Just, some people would want more information. I'll get a vibe that is the case, or others might just want limited information. So I'm going to give you the long one though. So I would start off by saying brain is a bit like a computer. I know there are commands coming in from everywhere in different forms and shapes. You make sense of it and you respond, etc. And when we move, that's exactly what happens. Our muscles that we use to move would have a little bit of a back and forth with the chief executive of the brain, the kind of that frontal lobe structures. And what happens is that when we move, without us kind of really consciously being aware, we are making sense of the environment, see how much should I move at all, or am I going to hit someone? There's a lot of that kind of considerations, but we don't even recognize it as happening. It's so intuitive, spontaneous. That's what muscles in the brain naturally do. And the same for the speech. We kind of, when we are speaking, we kind of have a little bit of some kind of judgment call going, the way in which I would address this person, the way I would say the same thing to a friend versus to a boss versus somebody else. So a lot of these back and forth happening. And if you were to just kind of release all these movements as they come, without those checks and balances or the breaks allowing you to make that judgment call, then you would be just kind of moving, or you'd be just blurting out things which you may or may not have considered or filtered or anything. It's just random things, right? So if I were allowed to just do that, so that's about what really happens. And the reason why it might be happening, this is just, again, evidence from some research that we've done. It's not, brain is very hard in that way to kind of get to understand. So the more we learn, the more we are humbled by the complexity that comes with it. But our current understanding is that in addition to that back and forth, there's also a strong gating mechanism called sensory motor gating. So we've got a lot of neurophysiological stuff happening up there. We are not even consciously aware of it. It just happens and it's just kept behind the gate. So we are not consciously aware of it happening. But when you've got a leaky gate, a little bit of that urges or sensory sensations leak out into the conscious awareness. So it's a bit like the sneeze coming, or a bit of an itch coming, or an urge to do something. Sometimes we feel it because there's a reason to do it, but other times it's all kept behind the gate. So when you get that sensory premonitory urge or sensation, urge to move, And if it creeps out into a conscious awareness, the natural response is to kind of complete it with a motor response, right? And so that urge, tick, relief, urge, tick, relief, urge, tick, relief cycle continues. And you might ask, why is it that it's different in, one brain versus the other? There are a number of reasons, mainly biological reasons like genetics play a role, because we all are the constitution of every part of the brain and every part of the organs are in their development in particular is influenced by the genes. There is one gene that would allow you to kind of make the building, which is the circuitry that I'm talking about, the kind of the networks or the connections. So it's almost like a building. There are some genes which are like the glue, adhesion glue type molecules, which is like your cement in a building, or there are scaffolding proteins, which is like your scaffold. It doesn't really matter which part of that was not right at that particular time when you're building a particular structure of the brain. So events happening at various times during pregnancy, etc., or triggers and the environmental immune triggers come in that way, in addition to that biological vulnerability, which if you have, it's not a single gene for autism or for ADHD or for Tourette's. We all know that neurodevelopmental genes are shared across, and also with many of the mental health conditions as well, obsessive compulsive behavior being one particular example, and ADHD, which kind of all come together as a package rather than most of the time you see a collection of all of these things. And so biological genetic predisposition is a critical thing. And it may be that there is somebody in the family who has got a mild little bit of obsessionality. You may not even know there's an aunt like that, right? Because it's just not known, or it's not proclaimed, or you haven't had a diagnosis. And tics in particular, when I take history from people, the parents and the family members, oh, his uncle did a little bit of that, but went away, or I did it a little bit in childhood. So they will kind of have some record, but some people don't even know they have it. You'll see on the trains or everywhere. If you start looking, you'll see them, right? Yeah. But they don't even know. So that's how it's kind of in the population level. But if you have family members with it, you will collect a lot more of those stress genes as a chance. And the more that kind of collection happens and you kind of reach a particular threshold, then it kind of starts to show it as symptoms. And then it starts to show it as symptoms severe enough to come for attention of clinicians and getting it diagnosed. Others are in the environment, in the population, in the families, etc. Yep. So very much, that's what's happening and why it's happening. But there's a good news story that I want to kind of add to it, which is that when the brain matures and develops, there's an opportunity for some of those inhibitory or brake circuitry to become alive a little bit more during maturation. That's why tics get better. They become much better connected and working functionally well. And we can give a helping hand, some of that behavioral methods of treatment where you catch the urge and prevent yourself from doing the tic through techniques that are taught, really gives a helping hand to that maturing brain to kind of make those kind of circuitry stronger so that you don't necessarily only do this vicious cycle. So yeah, medication improving the chemicals to make the gates and the circuitry work better if you have low levels, and also techniques that, all of that will help in terms of giving a helping hand and making things better. So as it is, a good chance that many people would have the tic symptoms much less in severity by the time they reach young adulthood. So there is that good news story that I would want to impart as well while explaining.
And along the lines of that, do we know why in some cases in later teens, some people do not improve? Do we know why that is?
Well, the understanding currently is that in postmortem studies, we have found that there are particular interneurons, which seems to have, during maturation, ended up in the wrong place. So in postmortem brains, what we have found is that those interneurons, instead of being in that caudate nucleus, it ended up in the globus pallidus. So what we believe is that maybe the genes that direct the migration of the neurons, because it got produced, all right, but it ended up in the wrong place, for example. So if you don't have those interneurons in the correct place in the caudate, it is almost like oscillation or a rhythmic oscillation that kind of like the heart rhythm and the oscillation, if you like, and that doesn't work very well. That oscillation and the synchrony doesn't work well. That's why deep brain stimulation of putting in the pacemaker type of thing kind of works in those severe cases. So if you don't have enough interneurons there, how much the compensatory development happens or maturation happens, that's not going to be, overcoming that. So we believe maybe some of those with more severe ones, it may be at that level rather than at the functional level that there is chance. Again, it is a matter of severity and how much each thing is involved, right? So, but this is one example of why, that's, we have also found that when you have got a small caudate nucleus in neuroimaging, the prognosis is not that great. So again, showing that those interneurons are physically missing, they have ended up in the wrong place, probably due to the gene that kind of directs that neuronal migration didn't do the job well because there was an issue with that. It's again, we are just making sense of available literature and research findings, but that's one way of understanding that phenomenon.
Okay. And with regards to the tics themselves, how do we distinguish between childhood tics and Tourette syndrome?
I would say it's a kind of it is a spectrum and it is a continuum, but about 20-25% of kids would have what we call a transient or a developmental tic, like you'll have a blink or a twitch and then it goes away. So one is that it's usually a single tic, not multiple as you would get in Tourette's. And if you see that it's lasting for longer time, so obviously, the transient tics are for shorter periods of time. But if it stayed for more than a year, of course, while waiting for more than a year, the things that you look for to see which it might be is if you have multiple tics going from one side to another, more complex one coming in, vocal tics coming in, there's family history. So all of those things will kind of make you think, oh, this is probably going in that direction.
Okay.
In those early days.
And similar to what you were just saying, when someone in the family has been diagnosed with Tourette's, when should they seek a specialist as opposed to allowing their primary care physician to treat it?
It will depend on your health systems in a way, like kind of where they get treated, whether they go to some GPs would be kind of okay to do some part of it in the early mild phases. Some countries, they wouldn't at all touch, straight to the specialist. So it will, with that caveat, I would say that I always say, look for 3 Ds. One, is it causing distress? Is it causing dysfunction? There's a significant impairment in functioning. Is there a significant deviation from what's expected for that age, gender, circumstances, etc.? And then if those 3 Ds are there, then you know that, when would you call a active, energetic kid to be having ADHD? It's the same question, right? Yeah. If you had a mild tic, and so what? If it's not causing any distress, it's not impairing your functioning, it's not drawing attention and producing, difficulties for you. It's not just really the tics, but also the consequences of it. People are kind of bullying them, or people are constantly talking about them. They're feeling so. That is the distress, right? So it doesn't necessarily mean the severity of tics. I would say look for those things to seek treatment and active treatment.
Okay. Another question. Your work focuses on early determinants of health. Are there early biological or environmental factors that influence neurodevelopmental conditions like Tourette syndrome?
Definitely biological genetic factors, without a doubt. But there are also a lot of environmental triggers. I'm not saying that it causes the tics, but a lot of triggers like stress, anxiety, excitement, fatigue, boredom, social gatherings, infections, inflammation. So again, so some people say when I'm bored, it's kind of worse. So some people say when I'm bored and not much happening, I'm better. So again, it's so variable, but there are definitely environmental triggers and immune infection type of things as well, which may be just unmasking or triggering, but definitely environmental factors along with the biological genetic factors, definitely.
Okay. From a child psychiatry perspective, what treatment approaches currently show the strongest evidence for tic management?
If you think about the ease of treatment, I would go with medication as the kind of one with which is stacking up, because I say that with caution. Behavioral methods of treatment like comprehensive behavioral intervention for tics was shown to have pretty much similar rates of improvement in well-controlled studies. But for me, it's more about that needing the young person or the adult, whoever they are at whatever age, a lot of motivation. The clinician should be kind of really doing it well, and the fidelity aspects. And, so there are a lot of other factors which may kind of, come in the way, although head to head, they may have pretty much similar outcomes. So I would kind of say moderate to severe, at least to start with. You want a quick response or a good response. For me, medication has got that edge, but that not at all taking away the fact that you don't need medication for everyone. That's just that end. For the mild to moderate, we usually start with behavioral methods of treatment, of course, or other things. And one of the the promising things is that a lot of other emerging treatments are coming in, like the neurostimulation, etc. So it may change, in 5-10 years time, and I may be talking totally differently. So there are a few things in the pipeline. So I need to be cautious in what I say at this point in time.
Okay. Are there protective factors that can improve resilience in children with Tourette syndrome?
One of the things that I have found time and time again is it's not the severity of the tics that makes or breaks in terms of resilience or what happens in outcomes. It's more about their approach to it. The people who take it on the stride, it doesn't kind of get them, although they have it, they do much better. So for me, much of the work, I think, should be about not so much about controlling and suppressing and all of that and techniques. It's about accepting it in a way. Don't start fighting with it. Already you've got enough things on your plate, and other people are going to kind of come and tell you or what you don't want to hear. So if you don't accept, and if you're not comfortable, and if you're not going to tell them, with chin up and say, well, I've got Tourette's and I do this, that's me, take what you get, and otherwise, that's it. So that kind of approach is really what resilience that I have seen is all about. It's not so much about, even if you control tics, sometimes you say, I've got that one tic, it may come at the wrong time, and they keep worrying about that one tic, it may come at the wrong time. I mean, you've controlled it so well, but they still their approach to that tic being part of them, or kind of being it. And most of the people, if you look at other neurodevelopmental conditions like autism, once you say that I'm proud of my neurodiversity, or I'm accepting it and I'm going to make accommodations, and the world around you also make accommodations, is the way you kind of treat it. That's, to me, that's kind of important.
Okay. I think with this next question, I think you've probably answered most of it, but from a global perspective, how do we reduce stigma around Tourette syndrome and neurodevelopmental conditions globally? Anything different than what you've already just said?
I think we are so behind to ADHD and autism in awareness, understanding among professionals, in the community, among the Tourette community, and also the outside community. Absolutely miles behind. And also, I feel that one of the problems is that it doesn't have a home. Most conditions have a home. They're just between neurology, psychiatry, psychology, the health system says this, that, and the other. There is no home. And therefore, it doesn't get taught well, because it's not part of a curriculum. You ask psychiatric registrars and, in our medical students or anyone, it's so variable. That can't be the case at this day and age for autism or ADHD. We wouldn't accept it, would we? But Tourette's, we accept that because we don't have a home. And secondly, we can't even have a global conference. Every other condition you take it, every other condition. Europe is the only one that has got the European Society for the Study of very successful conferences they run. But it's Europe. And that's because of a particular, I know the story about it, but because I trained in the UK. But Tourette Syndrome Association, US one, used to do a 10-year conference, and the last one was 2015 in London, and since then, in 2025, I asked whether we could organize one. And I think the fundraising or the kind of the vibe of the community, acceptance of it, or it being an important thing that we need to have a conference around, is not just happening. Each country has to struggle, if there is a champion or an advocate, to kind of make do. Start an association, start this, start the other, then you're fighting with the health services. They have not been taught, they don't know. Half the people think, oh, ticks, you just wait, and they go away. And, so we are caught up, we just have a long way to go, I would say. Global conference where all professionals come together, it becomes a thing. Everybody's looking forward to that conference, and the trainees are making papers or doing research, or they are interested because they can go to that conference. There is nothing like that for Tourette syndrome globally.
Interesting. Well, that's something to work on, definitely. I know from talking to some of the people I've interviewed and talked over the years. I mean, I guess you got the movement disorders group, and then I guess you have the psychiatric group, you have the psychological group. Like, everyone's, I guess, doing their own thing, but not everyone pulling it together in one concise,
Yeah, Totally. If you go to movement disorder, I would think that's a home, but that's Parkinson's and, your movement disorders from a neurology perspective. And there may be something on, but it's not, as I'm saying, that ADHD belongs to different camps too. But, autism belongs to different camps, not even in medicine sometimes. The part of the conference is with the community and, done in a different way. So we don't have that. And it doesn't have a home is precisely what I was saying earlier. Yeah.
Interesting. I'll leave you with one last question. What gives you hope about the future of child neuropsychiatry and Tourette syndrome?
And as I was alluding to earlier, we were kind of quite stuck with no new medications for a long time. We might borrow whenever new antipsychotic come, and we try and use it in Tourette's, and if it works kind of, but not not for a want of trying though. I mean, there has been a number of trials, etc. But it's with the behavioral techniques, or whether it is with medication. We were a bit stuck in terms of nothing new had happened for a while. But I have a little bit of hope now, as I alluded to earlier. A bit of that other neurostimulation and various other bits and pieces are picking up. We'll have to wait and see what the research evidence comes through, but there are promising starts. And so the median nerve stimulation being one particular one that comes to mind. So gives me hope that those kind of things are actively being pursued at this point in time, and we may have much broader variety of techniques and treatments to choose from in the future, is the hope.
Wow. Well, I'd like to thank you very much for your time and expertise on this. You've been very enlightening, and I'd like to thank you for supporting the Ryan Lawrence Tourette Syndrome Foundation, and hopefully we'll speak again sometime down the road.
Thank you very much.
Yes.